Thanks very much, and thanks, Dixie, for teeing this up, because this puts my talk in context. I'm going to talk very fast because I actually have quite a lot to say, since I have been dying essentially for this moment. And I don't mean for me to speak, I mean for us to do this. You're wasting my time. I know. We have an opportunity, and actually over the last few days, several people have said, do you really think so? You know, I'm kind of curmudgeon, or I'm, not so optimistic. And I think it's up to us. We have the answer. We absolutely hold the answer to this in our hands today and whatever we do forward, and it's up to us. So this is the moment. This is our opportunity. Engaging research participants, and I am thrilled that we are finally moved to a place that for years I've been saying, I am not a patient, I'm not patient. I don't want to be in a gown with my butt showing. It is time for us to be partners and participants, and I'm so happy the language of this initiative is caught up. So we want to be at the table, yes, but we also want to be planning the meal. So we also don't want to be just a token in the room brought to something else that somebody else has already brought together. This whole participation thing needs to be frictionless, and we've touched on this morning. This needs to be in the community with community leaders. It has to be where we live and play. It has to be in our pathway. If it isn't, it will not work. We are not going to go somewhere special, do something special. We all know that. We wish we would, and as we've pointed out before, we don't continue to. It also has to have relevance, value, benefit, whatever words you want to use. It has to be our questions. And you're going to note, I hope that throughout this, I'm using our language, because it is all of us. We are the participants, as well as who we used to think of as the patients, because that is us, who we used to think of as the researchers, because that is us. We are building a we. The results have to be visible and tangible, and while we always wait for the big, 2 years from now I'll publish a paper, and 5 years from now I'll think about integrating or implementing, and 10 or 17 years from now there'll be an uptake, I think we need to make that more proximal and continue to iterate on that. And we need to solve our problems, and I put a couple examples here. Taking your kids' immunizations to their schools every year, taking your mother's health record to a minute clinic so she can get a flu vaccine. If we can connect this to those kinds of things, which I believe we can, the technologies exist, people will want to play. And then this should be beyond advocates and advocacies, and I could go into a whole separate talk on this. We are over advocates and advocacy. That was an age, it was a great age. We are now into affinity, and affinity groups pop up all over the place about all kinds of things, and we need to connect with them. We're in the middle of a huge culture challenge, and these are only a few of the things I think we need to consider. It has to be empowering and not paternal, or paternalistic or maternalistic. We have to grow up investigators who are participants, clinicians, whomever, and not do helicopter science, not just come in with a medical mindset to something that's going to need something much bigger than a medical mindset. We need to set the passion of the people on fire, and it will fuel this initiative if we do that. We need to ask a lot, and we need to give a lot. We all play much better when we're in the game, giving a lot and asking a lot. We have to provide proximate on-ramps, again, easy, frictionless ways, a trust environment, which Dixie talked about and I'll talk some more about. We have to face our fears. We're afraid of people participating. Over and over I hear that for all kinds of reasons, and we put all kinds of screens up around the reasons. We are afraid, we hate to risk, we hate to change, and we also say but a lot. Just listen to us in this room. We always say, I really like what you said, but. So let's try and see what happens if we do that. We participants have to step up and stop apologizing. We have to stop saying, I'm just a mom with 2 kids who have a genetic disease. That's how I used to start absolutely everything. I have no credentials. Forget it. We have to stop apologizing, and we need to set up. And we need transparency so we can go, go, go. We can lead, we can follow, we can dance, we can run. We can forgive. We will forgive. We will all forgive each other. We're going to make mistakes. We're going to step on toes. We're going to breach privacy. We're going to do all kinds of stuff. If we're in a trust environment, we can forgive. This is going to be relational and not transactional, and that's going to be really different than what we haven't seen in the past. We have to watch our language, and I talked about that a little bit. We've already also here today, and we do this all the time, said, when we let patients engage or participate or partner, we're not going to let us do anything. We already have the power to do that. We belong here. We're supposed to be doing this. So being let to do it doesn't make any sense. And if this is real, then we are partners without needing permission. that's the participant side of that. I'm going to shift to the consent side now because I have two jobs here. I'm going to say get rid of the word consent, and let's replace it with engagement. I think Dixie showed us, and you really need to go back and read her slides because they really have a lot of content. Consent is supposed to be embodied in something bigger, fair information practices, and we've taken it out and used it because it's a transactional element. We can have a cash register and cash in and out. We want to put it back into the engagement, and that's not easy. It's very, very messy, but again, we can trust each other, we can forgive each other. Again, we're about process through this whole thing. This is going to be iteratively better and better, but it's going to have mistakes, and I love the airplane building it while we're flying an analogy. I constantly use it for PCORnet. It drives some people crazy. We don't have seatbelts yet. We don't have oxygen masks yet, but it's okay. We will be okay. I'm not going to read this whole slide because I think we've been talking about what we think might be the problem in consent. Lots of different ways to look at this, whether it's around access or the ability to follow people longitudinally or privacy issues, et cetera. And then I'm going to have this slide stand in for the lots and lots of good research, starting with stuff that Kathy did at the Genetics and Public Policy Center, all the way to 2014, this Robert Wood Johnson report, in between a lot of Pew reports, IOM reports, that told us the public wants to share, but the public wants to be asked. And the example I like is if I went to any of your houses right now and took your bicycle and rode off, you'd call the police. But if I ask any one of you, can I borrow your bicycle, you're going to give it to me. You'll probably tell me to keep it a year, you don't care. Especially since probably you're not writing it right now. But we all just want to be asked. We also try to do a one-size-fits-all all the time, and this is a graph that was in an IOM report by Dr. Alan Weston that essentially shows there's a range of ideas, concerns, issues around privacy. We cannot do a one-size-fits-all model here, and we put underneath it, these are not his, open consent, portable legal consent, HIPAA, et cetera, lots and lots of different models. So we want to be able to work along this continuum and to allow people that they are in certain places, and we need to adjust where they are with dynamic and granular settings. We also need this to be in their pocket. Again, frictionless, where they live, what they're doing. The program process that we put together is something called PEER, which is Platform for Engaging Everyone Responsibly. And here you see the dynamic kind of core of this in the middle, essentially putting the health data, the contact data in the system, which lots of people separate, using privacy directives to adjudicate what actually is the permitted information. And I'll show you a little bit how this works. A customized consumer portal and a researcher portal, and any kind of data can go into this. We start with in an environment of trust, which again I'll talk about. This we're looking at the Joubert Syndrome Foundation. We then move and put an iframe essentially into this website by putting our portal in there with some privacy preference setting tools that allow the contact information, the privacy directives to be laid down, then health information, surveys, medical information, et cetera, a survey that allows some interactivity, gamification. We have a data holder. Data seekers then look for this information and ping the privacy directives to understand whether or not this data can move and what data can move. I'll show that a little more clearly. This also allows enrollment for clinical trials when a large cohort comes together. We've seen that people trust the system, almost 90%. People are able to say allow, deny, or ask me. The ask me is the opt maybe. So we have opt-in, opt-out, and opt-maybe, so you can come back to me. We also have stratifications here in columns and rows that I won't go into, but essentially different levels of information being able to be used. Lots of people push back and say, this is too complicated, the average person can't do this. These guides have videos. They talk to you about why you want to do these. This is from the sickle cell community. Here's some from the pulmonary fibrosis community. Each of them tells a story and helps you with those settings, and you can set them up for other family members. There's an activity log, and again, you can consent from your phone. It's gamified, so you can see how you can stack up against others. You can be the same or different, which we found people like to be both. We're doing matchmaking between genotype and phenotype information to let parents make these kinds of associations, which they're very happy to do around their children who are not yet diagnosed. Again, we want to put this in your pocket. We want to make it gamified. We want to make it interesting. It's completely customizable. You'll see our third speaker, Andrea, is on the second panel here for Free the Data. We can configure it for whatever community using very simple web tools. It's deployed in a whole host of places. the PCORI PPRN that we run, white labeling project with Robert Wood Johnson, some campaigns for the FDA and others, advocacy groups, and the general public. I'm going to end with saying trust. It's all about trust, more so than privacy. Privacy is a red herring for trust, I believe. We really need to see where people are and what underpins that trust. When it's not present, people really feel it, which undermines that trust. If we place the person at the center and their interests in the center, always, and if we keep honoring that guiding principle, all the rest will follow. It must follow. It can follow. It will follow. Thank you.
Any clarifying questions? I know we're going to have a lot of questions when we come to the question period. Okay, thank you, Kathy. Kathy, oh, Sharon, wow. Yeah, I know it has been. You have just seen Andrea on the previous slide. You will, the red button will go off.